My pleasure to be here. Very honored by this opportunity. I'm currently in Brazil. I'm a professor at the Federal University of Bahia in the state of Bahia in Brazil, in the School of Collective Health, as we call it. Supposed to be a little bit different from public health, but that's another question, not a discussion. For now, I'd like to share my screens. I have four or five slides. So tell me if you can see it well. Yes. Okay. So I had this question as a starting point, as I got from Sunil for this session. How do you build a system where prevention and health come first through proactive layered action? And so I took the liberty, Sunil, to ask the IA what it would reply if we ask them that. And then I go one step further and I ask it for examples of this kind of approach. So it gave me very interesting initiatives that can be understood or classified as a responsive, strong health system that puts prevention and health first. We have in Brazil the family health strategy, focused in primary care, that develop organized territorial teams, outreach, integration with health systems. We have also in Finland, health in all policy, focusing on governance. In Colombia, urban reform related to stimulating the use of bicycles, and it needs to be built and built in environment. In India, a very interesting initiative, the Accredited Social Health Activists Program, focusing on community health with several, two or three layers of action. In Mexico, the soda tax, but the labels and campaigns focus on nutrition and several layers of action, also fiscal tools, regulation, education. In the UK, the social prescribing, especially for mental health, but the articulation of GP with community service and civic participation. And finally, in Ecuador, the Buen Vivir, the good life, the intercultural health with the indigenous knowledge. So we have so many good initiatives, successful initiatives, but as we may say, despite this multiplicity of successful initiatives, as it's stated in the term of reference of our domain here, the health domain for this session, the health systems continue to oscillate between crisis response and chronic underperformance and focus on treatment rather than prevention, despite all these good examples. So the question is why? What's lacking? Actually, we should acknowledge that these initiatives are very good, very strong proofs of concept. They show that we know what we need to do. We know and that these things that we need to do, they are feasible, they are viable, we can do it. However, you must acknowledge that they are drops in the ocean. Because the fundamental reasons to this difficulty of scaling up these kind of initiatives relate to political phenomena and power dynamics. Therefore, public health must engage and understand this issue. We need to act locally, but we need also to act globally. We need to think globally, but we need also to think locally. That is the challenge we have. Professor Martin McKee published a few years ago, which would be the attributes of public health leadership. 8 key attributes: ability to take the initiative, sense of curiosity to challenge assumptions and adapt strategies, broad perspective on health threats, recognition that some people, some institutions are opposed to health, willingness to speak truth to power, ability to engage with people in other sectors, commitment to values, and ability to communicate, combat misinformation, and improve trust. Concluding, I would remember that public health is always political. The lack of intervention on the structural cause of the multiple crises stems from the political strength of minorities who benefit from the current model, disproportionately appropriating socially generated wealth. Thank you very much.